Serotonin toxicity, also known as serotonin syndrome, is a collection of symptoms that develops from unusually high serotonin activity. It's mostly seen when a combination of drugs is used, such as a monoamine oxidase inhibitor with an SSRI, or with a substantial overdose of a single drug. If you'd like to see a written version of this overview, along with additional details, go to the TDC website page, which is linked in the description. With serotonin toxicity, the effects usually aren't life-threatening, and even severe cases can be readily reversed with appropriate medical attention, typically leading to a full resolution of symptoms within a matter of days. The effects exist on a spectrum. The mildest cases, which cause effects like altered mental status, increased heart rate, increased blood pressure, and sweating, may not meet the diagnostic criteria for ST, despite the symptoms technically being caused by serotonin. This means a threshold of sorts must be crossed for ST to be diagnosed. Classically, the condition has been defined as featuring symptoms from three categories: neuromuscular, which is arguably the most important, autonomic, and mental. It may be an underdiagnosed condition because a variety of other conditions can present with similar symptoms, especially with mild cases. And one report found a majority of clinicians are simply unaware of it. At the same time, the literature contains many reports of supposed serotonin toxicity that may not actually be ST. Most of the time, the potentially inaccurate reports are attributable to authors using the oldest diagnostic criteria for serotonin toxicity, described by Sternbach. Those criteria allow for a diagnosis to be made with primarily mental symptoms, and without some of the more serotonin-specific symptoms like neuromuscular changes, thereby making it easier to misdiagnose. The clearest reports of ST are those that have significant neuromuscular symptoms like clonus, hyperreflexia, or rigidity. When relying on other symptoms, it's possible for different conditions such as neuroleptic malignant syndrome, anticholinergic toxicity, malignant hyperthermia, and simple drug overdose or adverse drug effects to be diagnosed as ST. While not perfect, the Hunter diagnostic criteria may be preferable because they emphasize neuromuscular effects. Historically, the more common term for this condition has been serotonin syndrome, but because syndrome may imply an idiosyncratic or unexpected reaction, as with neuroleptic malignant syndrome, the term serotonin toxicity is preferable. The symptoms of serotonin toxicity are a reliable result of excessively high serotonin. The three main effect categories are mental, autonomic, and neuromuscular, and the most accurate diagnoses are made when a patient is showing symptoms from each category. A lot of the same effects can be caused by conditions that are not physically concerning, such as the normal use of MDMA. Many recreational drug users are unnecessarily concerned about serotonergic drugs due to being aware of serotonin toxicity and overestimating its likelihood. In reality, it's a pretty uncommon occurrence when a single serotonergic drug is taken at a normal dose, and some combinations that are listed as having a risk of ST are actually not that concerning. As a report in 2014 noted, a clinician who's searching drug interactions on a resource like drugs.com may be warned of 1,000 interacting drugs supposedly linked to rare but serious serotonin toxicity, yet it's primarily linked to just a couple dozen drugs from a few categories. Lab findings include increases in white blood cell count and creatine kinase. Someone experiencing ST will often initially be alert while also having symptoms like sweating, mydriasis, and increased heart rate, which are not life-threatening. When neuromuscular changes develop, they are more pronounced in the lower limbs. In more severe instances, the mental effects can deteriorate to agitated delirium. The most common neuromuscular symptoms are tremor and hyperreflexia, followed by muscular rigidity and hypertonia. Myoclonus is more common than clonus. Ocular clonus can include a range of abnormal eye movements, such as fine or coarse alterations of gaze in various directions. Those alterations can either be continuous or triggered by eye movement. While it has often been differentiated from neuroleptic malignant syndrome based on it supposedly having an onset of a few hours after the initiation of a serotonergic drug or a dose increase, this doesn't seem to be true. Symptoms can show up hours to days after a change in drug use. use, there's little agreement between the three diagnostic criteria, Sternbach, Radomski, and Hunter, which makes diagnosis harder. A 2016 meta-analysis demonstrated only 49% of cases meet all three criteria, and the Hunter criteria identified fewer cases with overdose, rhabdomyolysis, and intensive care treatment compared to Sternbach and Radomski, making it useful for clinicians to consider all criteria when deciding if someone has ST, rather than exclusively using the Hunter criteria. More severe cases, such as those requiring intensive care treatment, produce significantly more clonus, rigidity, hypertonicity, hyperthermia, and respiratory disorders. Respiratory compromise may come from rigidity affecting the truncal musculature and via separate serotonergic mechanisms. Elevated temperature is very common, though a temperature higher than 38 degrees Celsius is only seen in 60% of cases, and a temperature higher than 41.1 degrees Celsius is only seen in 9%. There are many similarities between ST and neuroleptic malignant syndrome, so considering a patient's drug use history is vital during diagnosis. Altered mental status, autonomic instability, rigidity, increased temperature, and increased creatine kinase can occur in both. However, NMS can often be distinguished by the presence of lead pipe rigidity rather than clonus or hyperreflexia, a lack of mydriasis, and exposure to antipsychotics or the withdrawal of dopamine agonists. Diagnosis can be complicated by drugs having persistent activity, such as irreversible MAOIs, or long half-lives. Factors like those have sometimes led to drugs causing ST despite having been discontinued days to weeks prior. This also means it is best to discontinue serotonergic medications for at least a couple weeks before starting a new one. Mild ST can be hard to differentiate from the mere non-toxic effects of a drug. Therapeutic SSRI use, for example, may cause altered mental status and some hyperreflexia or ankle clonus without toxicity, so it's easiest to diagnose the condition when there is a range of overt symptoms. The original diagnostic criteria were outlined by Sternbach in 1991, and those criteria are still the most widely used. They include the recent use of a serotonergic drug in at least 3 of these symptoms: mental status changes like confusion or hypomania, agitation, myoclonus, hyperreflexia, diaphoresis, shivering, tremor, diarrhea, ataxia, incoordination, and fever. Because the Sternbach criteria allow for a diagnosis to be made with primarily mental symptoms, there may be a higher than ideal risk of misdiagnosis. Radomski's criteria are pretty similar to Sternbach's, while differentiating between major and minor symptoms, as you can see on the screen. For the diagnosis, there should be at least 4 minor or 3 major plus 2 minor symptoms from the following list. The Hunter criteria, published by Dunkley in 2003, place far greater emphasis on a handful of neuromuscular symptoms, along with agitation and diaphoresis. In the presence of a serotonergic drug, if any of the following are present, then ST can be diagnosed: spontaneous clonus, inducible clonus with either agitation or diaphoresis, ocular clonus and either agitation or diaphoresis, tremor and hyperreflexia, or hypertonicity and hyperthermia, and ocular clonus or inducible clonus. Dunkley found severe cases had a temperature over 38.5 degrees Celsius and or significant hypertonia or rigidity, and in those cases there was a high risk of respiratory compromise, necessitating fast treatment with neuromuscular paralysis, intubation, and or assisted ventilation. Some of the conditions that overlap enough with ST to result in misdiagnosis are anticholinergic toxicity, malignant hyperthermia, NMS, drug overdose, benzodiazepine or alcohol withdrawal, meningitis, and encephalitis. The prognosis is very good when it's recognized early, the causal drugs are stopped, and supportive or pharmacologic treatments are initiated. ST has been fatal, and in severe cases it can easily be lethal if it's not quickly treated. Life-threatening ST occurs in up to 50% of people ingesting an adequate combination of an MAOI and SSRI. With treatment, the condition usually resolves in a matter of days without lasting effects, though altered mental status and muscle pain can can persist for a few days and occasionally longer. When fatalities occur, they're usually associated with issues like renal failure, disseminated intravascular coagulation, cardiac arrhythmia, hyperthermia, respiratory arrest, and rhabdomyolysis. The most common treatments include benzodiazepines, other forms of sedation such as opioids and barbiturates, cooling measures, and 5-HT2A antagonists like cyproheptadine and chlorpromazine. 5-HT1A agonism has often been listed as the primary mechanism in ST, but a lot of animal and human evidence supports a greater role of 5-HT2A, particularly in moderate to severe cases, making 2A antagonists more useful than 1A antagonists. For severe ST, intravenous chlorpromazine appears to be the most effective, while in moderate cases, oral cyproheptadine can be used, though it's unclear if its general sedating effects or its specific 2A antagonist property is responsible for the efficacy. Hyperthermia is pretty common, and it's a major source of toxicity. Despite this, dantrolene and antipyretics are not recommended as they target temperature increases that stem from mechanisms unrelated to those seen in ST. Benzodiazepines are a non-specific way to treat some of the core symptoms, including increased muscle tone and agitation, since they can reduce sympathetic activity. They are very effective, but sometimes alternative treatments are required to yield any response. Toxicity is greatest when hyperthermia and increased muscle tone, clonus, or hyperreflexia are inadequately treated, making aggressive treatment important in severe cases. Rhabdomyolysis is a fairly common complication in severe cases, although the majority of ST cases don't lead to it. Occasionally, other severe conditions, like disseminated intravascular coagulation, can develop. Non-depolarizing neuromuscular blockers, like vecuronium, are recommended in instances where muscle tone is not adequately controlled by benzodiazepines. Drugs to avoid include succinylcholine and bromocriptine. Succinylcholine should be avoided because of the risk of arrhythmia from hyperkalemia caused by rhabdomyolysis. Bromocriptine, which is dopaminergic and a 5-HT1A agonist, has been found to worsen symptoms when patients are accidentally treated as if they have NMS. Serotonin is synthesized from the dietary amino acid tryptophan, which undergoes hydroxylation, the rate-limiting step, inside the cytoplasm of neurons and other cells. From there, it's decarboxylated to form serotonin, and it's stored in vesicles for release upon depolarization. Because serotonin doesn't readily cross the blood-brain barrier, it must be independently produced, peripherally and centrally. In the periphery, it's mostly made by intestinal enterochromaffin cells, and centrally it's produced by nuclei in the lower pons and upper brain stem, regions that have axonal projections to many parts of the CNS. The level of serotonin inside and outside the CNS is normally tightly regulated by cellular uptake via the serotonin transporter and via metabolism to 5-HAIA by the enzyme monoamine oxidase A, which is present on the mitochondrial membrane. But enough serotonin to cause toxicity can accumulate, most often when multiple drugs are used or a single serotonergic is overdosed. 7 types of serotonin receptors and many subtypes exist, though 5-HT2A is the primary receptor implicated in ST, with possible, though inadequately confirmed, contributions from 5-HT1A and 5-HT3. It's been proposed 5-HT1A, a more abundant receptor, may be involved in the minor to moderate symptoms of ST, while overactivation of 2A is vital for all or most of the truly toxic effects. This is potentially supported by the finding that the combination of 5-HTP and an MAOI, which is known to cause ST, yields hypothermia at low doses and hyperthermia at higher doses. 1A is more common and a much higher affinity site for serotonin than 2A, so high serotonin levels will initially cause more effects via 1A. Indirectly from increases in serotonin activity, there may be a rise in glutamatergic, noradrenergic, and dopaminergic function, which could play a role in the physiology of ST. Some of the autonomic symptoms, like diaphoresis and tachycardia, point to a role for hyperactive noradrenergic activity. Many of the symptoms are primarily mediated by central effects, but peripheral activity could be important in neuromuscular activity, vomiting, and diarrhea. Hyperthermia appears to be caused in large part by excess muscular activity, so a change in the hypothalamic temperature set point from a pyrogen is not involved, which is why antipyretic drugs are not used in treatment. Because physical restraints can increase the impact of muscular contractions, raising the risk of lactic acidosis, hyperthermia, and rhabdomyolysis, they should be avoided. Though not the result of pyrogen activity, some reports have noted hyperthermia may be partly coming from activity at hypothalamic 5-HT2A receptors, which could impair temperature regulation. Some researchers have proposed ST shares some of the same pathophysiology as NMS, because high serotonin levels could potentially depress dopamine activity in some regions, producing a relatively hypodopaminergic state and therefore extrapyramidal symptoms, like when someone takes a dopamine antagonist. Though, the two conditions still have significant differences, mechanistically and symptomatically. When ST was less well known, some cases of obvious ST were actually described as neuroleptic malignant syndrome without neuroleptics. Individuals could have different susceptibilities to ST due to genetic differences at serotonin receptors, enzymes involved in drug metabolism like CYP2D6, and P-glycoprotein. In the musculature, serotonin can increase the frequency and duration of firings, leading to clinical symptoms like tremor, clonus, and hyperreflexia. Stimulation of central 5-HT2A is linked to hyperthermia, while 1A causes hypothermia, implicating the former in the generation of ST. Similarly, animal models have found 1A agonism decreases heart rate and blood pressure, while 5-HT2 agonism does the opposite, and indeed, increased heart rate and blood pressure is much more common than low blood pressure and heart rate in ST. Metabolic analysis in rats with ST, induced by 5-HTP and MAOI, showed hyperthermia could be coming from an increase in the expression of the mitochondrial protein UCP3. Many metabolic changes were found in the muscles, the liver, and plasma during ST, along with a rise in UCP3 in the gastrocnemius muscle, but not the trapezius. There was a significant increase in urea cycle metabolites and signs of anaerobic respiration. Downregulation of serotonin receptors may be protective against ST. Chronic MAOI administration has been shown to protect against ST-like symptoms in rats. The protection was associated with a decline in serotonin binding sites in the brainstem and spinal cord. Serotonin availability is required for the presentation of ST, just as serotonin receptors must be adequately available. The effects can be blocked by parachlorophenylalanine, which inhibits serotonin synthesis. A 2011 study found 5-HTB is protective against ST in mice. When it's absent, such as with 2B knockout mice or with a 2B antagonist, serotonin toxicity is significantly enhanced. It's possible the reports of convulsive ergotism stretching back to the 11th century may have involved serotonin toxicity. The symptoms reported in those cases included distortion of trunk and limbs, ankle flexion or extension, drowsiness, mania, hallucinations, diarrhea, sweating, fever, muscle stiffness, and twitching. Ergot alkaloids are known to stimulate 5-HT1 and 5-HT2 receptors, giving a potential route to ST. The modern history of ST goes back to the 1950s. It was first reported in humans treated with MAOIs in the early 1950s to 1960s, sometimes with it being prescribed alongside tryptophan. A dose-response effect was found with tryptophan combined with MAOIs, with effects ranging from an altered mental state all the way to ST just with tryptophan. A report in 1955 described a patient with severe muscle twitching, ankle clonus, and Babinski signs who was given a pronazide and MAOI with the opioid meperidine. The condition was further described by Oates, who reported mental changes, restlessness, lower extremity hyperreflexia, and diaphoresis in 4 patients in the early 1960s. They attributed the symptoms to excess serotonin activity caused by the use of high tryptophan doses with MAOIs. Oates also gave people 20 to 50 milligrams per kilogram doses of tryptophan with an MAOI and reported it caused dizziness, drunken-like effects, clonus, restlessness, hyperactive reflexes, and diaphoresis without significant cardiovascular changes. Hoge reported giving 5 hypertensive patients a decarboxylase inhibitor before they received an MAOI, and this was shown to block nystagmus, jaw tremor, hyperreflexia, clonus, sweating, and intoxication, which implicated serotonin in the condition. Between the mid-1950s and early 1980s, there were many case reports of serotonin toxicity. Even by 1962, there were already at least 20 separate reports of apparent ST in dozens of patients. 18 involved MAOI MAOIs with imipramine, causing 7 fatalities, and 10 involved MAOIs and meperidine, causing 3 fatalities. Nearly all were reported without the authors connecting the observed effects to the ST-like condition that had been reported in animals, so it would take decades for ST to be well understood and widely known. The term serotonin syndrome was first used in animal research in the late 1970s, and then in a human case in the early 1980s. The first ST-related death to receive substantial attention was that of Libby Zion in 1984. It is believed she died from an interaction between the MAOI phenelzine and meperidine. Her death eventually led to nationwide regulations in the US to limit working hours among medical staff. By the 1980s, various drugs had been shown to counteract ST in humans and animals, including chlorpromazine, thiothexine, clozapine, pimozide, and cyproheptadine. Given what was known about those drugs at the time, their efficacy appeared to be evidence of a substantial role of 5-HT2A in the disorder, since those drugs are generally much more potent at 2A than 1A. Sternbach laid out diagnostic criteria for ST in 1991, based on a review of 38 case reports, in which the symptoms included restlessness, confusion, myoclonus, hyperreflexia, sweating, shivering, and tremor. Nearly all of those cases came from the use of antidepressants with other substances. In 2001, Radomski published an updated diagnostic criteria based on a larger review of 62 cases, which included Sternbach's original 38 and differentiated between major and minor symptoms, along with adding rigidity to the list of neuromuscular symptoms. Another set of criteria was published in 2003 by Dunkley, using over 2,000 cases of SSRI overdose in order to more precisely identify serotonin-specific effects, leading to the conclusion that an excess, specifically of serotonin, will yield clonus as the most important diagnostic symptom. Dunkley's Hunter criteria limited the role of mental symptoms in the diagnosis, which has often been considered a good way to increase precision. However, the fact that it only used SSRI overdose cases could make the outlined symptomatology less applicable to other types of serotonergic drugs and to combinations, so strictly using the Hunter criteria may lead to some false negatives. In conclusion, serotonin toxicity is a real condition and is life-threatening in severe cases. You can essentially prevent it just by avoiding certain drug combinations and by avoiding overdoses. MAOIs should almost never be mixed with other serotonergic drugs, and other combinations need to be utilized with careful attention to the effects so that the dose or combination can be adjusted at the first sign of a problem. Even though researchers and physicians have been writing about the condition for more than half a century, serotonin toxicity is still inadequately understood, so it may be underdiagnosed and frequently misdiagnosed. If you do suspect you have the condition, even mildly, it may be necessary, at least temporarily, to stop taking any serotonergic drugs, and you should consult with your physician to figure out the best course of action. Simply stopping the drugs and perhaps using a benzodiazepine will usually be adequate in mild cases. With anything more substantial, especially any case that meets the outlined criteria for serotonin toxicity, you should seek medical care to ensure toxicity is prevented. With all of that in mind, the careful use of serotonergic medications, psychedelics, and entactogens carries very little risk of serotonin toxicity, so as long as you're smart about your use, you should be fine. The Drug Classroom is a listener-funded resource, so your support is what allows this content to exist. If you want to donate, you can do so through Patreon, PayPal, or Bitcoin. Donation details are available in the description and at thedrugclassroom.com/support. Your support is greatly appreciated.